I'm Dr. Randy Martin. We're here at the 2023 AATS Mitral Conclave. A lot of interesting data now on really the treatment of AFib, but really arrhythmias in general. And I'm joined by two colleagues, Eric Lehr and Niv Ad, who we're going to be talking about two different trials that you both are heading up. Eric, tell me about the Terminate AF trial.
Well, thank you, Randy. The Terminate AF trial is designed to assess the Medtronic cardioablate devices and try to expand the indication from just a general indication for the ablation of cardiac tissue to actually have an indication from the FDA for the treatment of atrial fibrillation. And so that's the primary goal.
So this is intraoperatively, right, being done?
Yeah, so this is done for concomitant procedures for patients that are coming to the operating room with a pre-existing diagnosis of persistent or long-standing persistent atrial fibrillation.
So for the audience who may not know, what is the technology that's being used?
So it's a combination of two different technologies. One is a radiofrequency or irrigated radiofrequency bipolar clamp. That is probably the predominant workhorse for the procedure, but also for a cryoablation probe.
Okay. And Niv, you're working on the ICE-AFIB trial. Tell me a little bit about that.
Yeah, so that's a second trial in a row for the AtriCure platform for cryo, and that means it's a freezing technology. It can be used as a single technology to apply all the lesions of the MACE procedure, and the trial is designed again for open sternotomy, concomitant procedures, cabbage, valves, valve cabbage, the majority of them, and for patients that have exhibited persistent and long-study persistent atrial fibrillation with a left atrial size of 7 centimeters or less as defined by preoperative echo.
The patient selection is done by the surgeon at the time of the procedure, the surgical procedure?
The screening is done before the procedure.
Okay.
And the patient has to check all the boxes. The most difficult one is the atrial fibrillation definition and inclusion. Right. It's the most challenging one to establish because sometimes records are not there. Right. So you have to run through halters and stuff like that. But the patient is being screened prior to the procedure, and it may be basically screen failed after you open the chest and you see something unexpected.
What are the outcomes that you're looking for?
So we have obviously the endpoints are efficacy endpoints and safety endpoints. Right. The efficacy endpoints is basically freedom from atrial fibrillation or any atrial arrhythmia throughout the first 12 months. Okay. There is a range that it depends on general control of the data that is already being gathered, and also freedom from atrial arrhythmia when you're using a class 1 or class 3 anti-AV drugs that failed prior to the procedure.
Okay.
The safety endpoints are the regular safety endpoints that are major. The major one obviously is death, stroke, and major bleeding and renal failure associated with the procedure. But there are some other less critical endpoints.
How long is the study for? What's the duration?
So the study, we follow the patients actually for longer than 1 year, but the submission to the FDA is going to be for those efficacy and safety endpoints after 12 months, but there are 2 and 3 years and so on afterwards that are going to serve as continuum of.
And what's the status of the trial right now?
Based on the power analysis and everything, we were supposed to enroll 150 and we enrolled 149. Yeah, so next week we are going to
reach 150.
Conclude. Yeah, we're going to conclude. We already have the patient that is out there. We are very excited about it.
Yeah, that's really good.
Yeah.
That's fabulous. Eric, tell me a little bit more about Terminate AF.
The study designs are very similar, and not surprisingly, given the updated guideline. Sure. And so in terms of efficacy, it's really the same. We're looking at outcomes at both 6 months and at 12 months.
Right.
And that's a Holter monitor test. And we're looking for a failure is anything more than 30 seconds of atrial fibrillation on the Holter monitor for 24 hours, or 10 seconds of atrial fibrillation on a spot EKG. And so those endpoints are measured at 6 months and 12 months. And then there's also a safety endpoint, which is again similar. It's a composite endpoint, primarily of death, stroke, myocardial infarction, a few other things, and then also specific to atrial fibrillation, esophageal injury, And so those would be the two endpoints.
Where does this trial stand in its enrollment status?
It's moving along. There's been 132 patients that have been enrolled. 85, well, actually now 87 as of this week, patients have been treated. And several, many more have, about 50 more then have been enrolled but not yet treated. It's also this Bayesian Goldilocks design strategy. So we look at the results of those patients treated to go back and inform the sample size. And so we have an investigator meeting at the ATS on Monday. And I think the statistician will give us an update as to how many more patients that we need to enroll.
The idea here is to get FDA approval, obviously, for this. Obviously for it to work and be safe and effective, but to get FDA approval, that process, let's say they both have positive outcomes, that process is, how long would you anticipate?
It depends on again, as Eric said, and our experience with the ablate trial before that, we actually needed less patients that we anticipated as we started to gather the information. So, but the worst case scenario is a year after the last patient being enrolled. So basically this time next year we should have the final results if we need all the patients. If we are lucky, then at some point, anytime between now and a few months from now, it depends on how well we did.
How would both of these trials impact what is the current therapy being done now?
If you look at the number of patients coming to the operating room with atrial fibrillation that
are being treated,
it's really small. It's, at best, it's probably 2/3 of patients that come to the OR with mitral disease, and maybe at best 1/3 with coronary disease.
Right.
And so having devices that have been proven and vetted through these trials will hopefully expand the devices that are available, and then also allow the companies to provide more education on how to do these procedures.
Yeah, we were talking.
That's really what's lacking.
I was talking about that with Mark Gillenhoff this morning. I mean, basically, your patients come with indications. They could be class 1 or class 2 indications, and they're just not being done.
They're not.
I mean, people are thinking, well, I'll get my EP guys and gals to do it sometime else in the EP lab. And I think that's a mistake. I mean, you're there, you can visualize.
Yeah, it's not just that. I think it's a combination of things. So when we cannot talk about treatment freely and communicate, the indication, the contraindications, so on and so forth, then we cannot actually communicate what's important to patients. So we know that term atrial myopathy, when it comes to atrial fibrillation, it's a real deal.
Yeah.
It's a selection bias actually against catheter-based procedure. It will make it even less effective in this subgroup of patients. So it's really important to gain the indication, I think, for both companies, because it will elevate the visibility and the ability of the entire field to move forward and have those serious discussions about the need to do it and what to do. Because the other thing is that when you have non-mitral patients, for instance, it's a very, very low penetration, even in a long-term persistent, to do anything more than just PVI, which is completely ineffective.
Right.
We know it from the catheter-based world and definitely from our surgical world. But even in the mitral world, beyond left atrial ablation, even in a persistent, it's probably about 50% of the time. So this will allow us, I think, company side, as people that have very serious interest in this field to
Push the field forward, and more effectively treat patients.
Yeah. And I think along that line, it would be unconscionable to bring a patient needing a CABG to the OR, not put a LEMA into the LAD, because that confers us long-term survival advantage.
Absolutely.
Yet the long-term survival advantage when we treat atrial fibrillation surgically, especially with the Cox-Maze-4 procedure, probably exceeds the survival benefit of the added life given or pretended by a LEMA to the LAD.
Yeah.
So here we're very focused on one aspect of preserving life and extending life, but there's another massive subset of patients that come to our OR and aren't given that same advantage.
And for a significant risk, which is AFib, not only risk for stroke, but for morbidity.
Exactly. And the paradox, actually, if you look at the Medicare population, it's even worse, older patients. The paradox is that we say, okay, mitral patients, they have AFib, higher rate and so on and so forth. That's true, but the most patients with AFib that any surgeon will ever see are the CABG patients, because the denominator is so big. So even though it's 8% of them, it's the most patient we see, and yet only 20 to 30% of them are being treated any treatment, let alone
Yeah,
inappropriate.
you look at the population with hypertension and
Yeah.
all that. I mean, it's really. Well, I think these are both outstanding trials. We'll be looking forward to the outcome. And I think doing what you're saying is basically to treat the patients for something that they need to be treated for that's safe and effective. So
Yes.
thank you both for joining me.
Thank you.
Thank you for joining us, and stay tuned. These are exciting trials.